Hi, I'm Dr. Fox, and let's talk about the foregut, the stomach specifically. In this video, we'll discuss the organs that comprise the foregut, as well as the features, regions, relationship, blood supply, and innervation of the stomach. So first off, what is the foregut? The foregut references an embryological region, and in the context of the digestive system, the foregut consists of all of the organs that are derivatives of that embryological region. And that includes the abdominal portion of the esophagus, the stomach, and the proximal duodenum. So the duodenum continues on after the transition to the midgut into the jejunum. And so between the foregut and the midgut, there is an anatomical boundary point called the major duodenal papilla. The major duodenal papilla is an eruption of mucosa into the lumen of the second part of the duodenum that receives secretions from the liver as well as the pancreas. And so those accessory organs are going to be anatomically associated with the foregut, but functionally, because the secretions go in there, functionally they're more associated with the midgut. This region is predominantly served by blood through the celiac trunk, which is the first major branch of the abdominal aorta, and its branches. So let's take a look at the stomach. The stomach is an intraperitoneal organ of the foregut. It is preceded by the esophagus. It receives boluses of food through the cardiac orifice into the cardiac region. And then the stomach is going to mechanically and chemically break down that food, those boluses, into a substance known as chyme. The stomach along the gut tube is succeeded by the duodenum. And so you have chyme ejected through the pylorus, through the pyloric orifice, into the proximal or first part of the duodenum. The stomach, very thankfully, is an expansive organ. So as you receive more and more and more, and sometimes even more food into it, it is going to stretch to accommodate those boluses. When it is not distended, when it is back in its condensed or relaxed state, within the stomach you can see ridges of mucosae, and these ridges are called gastric rugae. So rugae are ridges, and these gastric rugae are just ridges of mucosa in a relaxed, non-distended stomach. So the stomach has several regions to it. So the main part of the stomach is the body of the stomach. The body of the stomach is going to contain that cardiac region into which boluses move. There's also a fundus, which means floor of the stomach, and a pyloric part of the stomach. So the fundus, the body, and the pyloric part of the stomach. The fundus, you want to pay attention to where that cardiac notch is anything above the cardiac notch. Anything below that would be the body. And then there's something called the angular incisure. That angular incisure is that point, that reflection point of the lesser curvature, and you take that obliquely, left laterally, and that is going to prescribe the boundary between the body and the pyloric part. That pyloric part is all medial to the angular incisure. There's an antrum, a pyloric antrum, and that is just a funnel where it begins to narrow that's going to feed into the pyloric canal. That pyloric canal is medial to that intermediate sulcus there, and it houses a pyloric sphincter. So a sphincter is an area of robust, smooth muscle that keeps the lumen occluded. And as the stomach goes through its stages of contraction, you don't want to release anything into the duodenum that isn't digested enough to become chyme. That chyme is going to move through the sphincter. So as we have excitation of the muscularis, we'll also have relaxation of the pyloric sphincter. Recall we also have omentum associated with the stomach, both a lesser omentum associated with the lesser curvature of the stomach, and that is going to connect the liver to the lesser curvature via the hepatogastric ligament. And then the greater curvature of the stomach has both a gastrophrenic ligament connecting that greater curvature to the diaphragm, a gastrosplenic ligament connecting the greater curvature to the spleen, and a gastrocolic ligament connecting the stomach back up to the transverse colon, which is going to be a quad layer of visceral peritoneum. Now the blood supply to the stomach. It gets to be kind of complex, so let's look at this from a 10,000-foot view. Let's look at the greater curvature and the lesser curvatures of the stomach. So the greater curvature is bigger, the lesser curvature is smaller. The lesser curvature is served by gastric branches. There is a left and a right gastric artery. The left gastric artery comes off of the celiac trunk directly. The right gastric artery comes off of the hepatic artery proper. And so the two of these come together in anastomose, or connect, along that lesser curvature. The greater curvature is served by gastroomental arteries, also known as gastroepiploic arteries. So there is a left and a right gastroomental artery. The left gastroomental artery is a branch of the splenic artery, which is coming down here. The right gastroomental artery is a branch of the gastroduodenal artery, which is coming along there. And these are going to anastomose to serve the greater curvature of the stomach. And there are other smaller branches, such as splenic branches from the splenic artery, gastric branches from the splenic artery, etc. But the gastric arteries and the gastroomental arteries supply the lion's share of blood to the stomach. Now let's look at the innervation. So the stomach is under enteric control, which is modified by the autonomic nervous system. And most of that autonomic fiber is enmeshed in something known as the celiac plexus. So autonomic fibers love to travel via paravascular plexuses. These are collections or meshes of fibers that follow arteries along. They're oftentimes named for the arteries that they follow. So the celiac plexus is going to be in association with the celiac artery, which we can see there. That celiac plexus is going to have two major inputs. There are thoracic splanchnic nerves that descend down from the thorax, and there is the posterior vagal trunk, which also comes down to the thorax. Now, all of these fibers are going to participate in this celiac plexus, which is a mixed autonomic plexus, both sympathetic and parasympathetic. Sympathetics coming from the thoracic splanchnics, parasympathetics coming from the posterior vagal trunk. In addition to this, we also have inputs from the anterior vagal trunk. Now, in terms of the abdominal pelvic cavity innervation, most of the parasympathetic input is coming from the posterior trunk, some from the pelvis, which we will discuss at a later date. And we have just a little bit supplied by that anterior vagal trunk. That anterior vagal trunk hits like the cardiac region of the stomach, as well as a little bit of the liver and the biliary pathway. Now, in terms of these divisions, parasympathetic versus sympathetic, recall that the parasympathetic is the rest and digest. So this is going to be the component that is active during digestion. And so with parasympathetic stimulus, we have increased motility of the gut tube, open sphincters along the gut tube, and vasodilation, or we have the wide opening of the vasculature which serve the stomach. We can contrast this with a sympathetic response, which is a fight or flight response. This is what happens when you are, in mortal combat with another individual or thing, where your life may be on the line, or maybe you're just anxious about an upcoming exam. With a sympathetic response, we have decreased motility of the gut tube. The gut tube sphincters close, and we have vasoconstriction of the vessels serving the gut tube. So there's not a lot of action going on in the gut tube when you are in the fight or the flee of your life. And let's just take a quick moment to discuss referred pain from the stomach. To do this, we need to talk a little bit of a different system of how we can categorize the abdominal pelvic cavity. So you're familiar with the left upper quadrant, the right upper quadrant, etc. But here we have an epigastric region, an umbilical region, a hypogastric region, hypochondriac regions flanking the epigastric region, lumbar regions flanking the umbilical region, and iliac regions flanking the hypogastric regions. Now, referred pain is when you can feel visceral pain in a region. Referred pain is pain stimulus that comes from general visceral afferent fibers. Usually, this is from compression feelings, but it could be an actual trauma to the area. In the case of the stomach, general visceral afferent fibers are going to travel along with sympathetic fibers. And because those sympathetic fibers are coming from the celiac plexus and up through the thoracic region, referred pain from the stomach is going to radiate in the epigastric region. So if you were to palpate kind of where your ribs and sternum ends, that's your epigastric region, and that's where you're going to feel referred pain from the stomach. So we've talked about the foregut derivative organs and which are part of that foregut, the various features, regions, and relationships of the stomach, as well as the blood supply to the stomach, the innervation of the stomach, and where we would feel referred pain from the stomach. Thank you so much for your time, and I'll talk to you later.